Bismillahirrahmanirrahim. Rabbi zidni ilma. You can't go back and change the beginning, but you can start where you are and change the ending. Assalamu alaikum everyone. My name is Dr. Sadia Rafiq, and under the supervision of Professor Dr. Saira Afzal, today my topic of presentation is cholera. Learning outlines includes introduction of cholera epidemiological triad, chain of transmission, clinical stages, level of prevention, and recent advances. Learning outcome. At the end of these presentations, participants will be able to describe the epidemiological triad and prevention aspects of this infection, explain the factors that contribute to spread and knowledge of recent advances. So starting with the case study of the cholera conducted in Pakistan. Case presentation. A patient was 27 years old. He was infected by eating contaminated food and water by eating uncooked food or contaminated fruits. After a 24 to 48 hours, symptoms began with a certain onset of painless watery diarrhea that quickly became voluminous and followed by vomiting. He vomits if he eats or drinks anything. After a day, his color became pale yellow and he became weak due to dehydration by loose motions and vomiting. In the first day of infection, he drank some rehydration solution, but it was not very effective. He experienced accompanying abdominal cramps, probably from distension of loops of small bowel as a result of the large volume of intestinal secretions. Fever was absent. He went to the hospital where proper checkups were performed. Doctors advised him for a few tests like CBC, ESR, rapid stool test to identify cholera bacteria. Doctor confirms cholera by identifying bacteria in a stool sample, checked the reports properly, and gave him first-line therapy. So starting with the cholera. If we see the fact sheets by WHO, cholera is basically acute diarrheal disease that can kill within hours if left untreated. Provision of safe water and sanitation is critical to prevent and control the transmission of cholera and other waterborne diseases. Researchers have estimated that each year there are 1.3 to 4 million cases of cholera and 21,000 to 1,43,000 deaths worldwide due to cholera. Starting with the history, 7 cholera pandemics have occurred in the last 200 years, with the first pandemic originating in India in 1870. It was the first pandemic, and the 7th pandemic was in 1961 to 1975. Outbreaks occur across the developing world to the current day. Epidemics occur after war, civil unrest, or natural disaster, when water and food supplies became contaminated with Vibrio cholerae and also due to crowded living conditions and poor sanitation. Additionally, there have been many documented cholera outbreaks, such as 1991 to 1994 outbreak in South America, and more recently, 2016 to 2021 Yemen cholera outbreak. First cholera vaccine in 1879 to 1883, major scientific breakthroughs towards the treatment of the cholera developed. The first immunization by Pasteur, the development of the first cholera vaccine. The identification of the bacterium, Vibrio cholerae, was by the Filipino Pechinay and Robert Koch. Introduction. Cholera is an acute diarrheal disease caused by Vibrio cholerae 01, which is also called classical or EL-TOR. Commonly due to EL-TOR biotype, case ranges from symptomless to severe infection. Majority of infections are mild or asymptomatic. Typical cases are characterized by sudden onset of profuse, effortless, watery diarrhea, followed by vomiting, rapid dehydration, muscular cramps, and suppression of urine. Unless there is rapid replacement of the fluid and electrolytes, the fatality may be as high as 30 to 40%. Epidemiological features. Cholera is both an epidemic and endemic disease. The epidemicity and endemicity of the disease will depend upon the characteristics of the agent and the environment. Epidemiological determinants include the agent, host, and environment. Starting with the agent, Vibrio cholerae, it is a gram-negative curved bacteria. The organism that causes cholera is labeled as Vibrio cholerae 0 group 1 or Vibrio cholerae 01. The term epidemic strain is used for these Vibrios. Within the 0 group 1, 2 biotypes, classical or EL-TOR, have been differentiated, but now mostly cholera is caused by EL-TOR biotype. Classical and EL-TOR biotype Vibrios are further subdivided into 3 serological types named Inaba, Ogawa, and Hikojama. Most of the EL-TOR biotype belongs to Ogawa serotype. The thing which is needs to be remembered, it is that EL-TOR biotype is the one type which is mostly involved in the cholera. Resistance. Vibrio cholera killed within 30 minutes by heating at 56 degrees Celsius or within a few seconds by boiling. Remains in ice for 4 to 6 weeks or longer. Dying and cyanide will kill them in a few hours. They are easily destroyed by cold touch disinfectants such as Crestol, bleaching powders, and another good disinfectant. Toxin production. Vibrios multiply in the lumen of small intestine and produce an exotoxin, which is enterotoxin. This toxin produces diarrhea through its effect on cyclic AMP system of mucosal cells of small intestine. Exotoxin has no effect on any other tissue. Infective dose. Cholera is dose related. Infection occurs when the number of vibrios ingested exceeds the dose that is infected for the individual. Host, age and sex, all ages and both sexes in endemic areas, attack rate is highest in children. Gastric acidity is an effective barrier. The Vibrio is destroyed in an acidity of pH 5 or lower. Conditions that reduce gastric acidity may influence individual susceptibility. Third is population mobility. Movement of population, for example, pilgrims, marriages, fairs, and festivals result in increased risk of exposure to infection. Economic status. Incidence is highest in lower socioeconomic groups and mainly it is due to poor hygiene. Immunity. Natural infection confers quite effective immunity and is mediated by local intestinal immune system. Vaccination gives only temporary partial immunity for 3 to 6 months. Environment. Poor environmental sanitation include contaminated water and food. Flies may carry Vibrio cholerae but not vectors of proven importance. Social factors responsible for the endemicity of the cholera comprise of certain human habits favoring water and soil pollution, low standards of personal hygiene, lack of education, and poor quality of life. Chain of transmission. Reservoir. Human being is the only known reservoir of cholera infection, maybe a case or a carrier. Cases. Inapparent infections to severe. In cholera AL-TOR, most infections are mild and asymptomatic. It is the mild and asymptomatic cases that play a significant role in maintaining endemic reservoir. Carriers, usually temporary, rarely chronic. They also make important contribution to the reservoir of the infection. Since carriers exceed fewer vibrios than clinical cases, carriers are best detected by bacteriological examination. Carriers in cholera, there are 4 types. Number 1 is preclinical or incubatory carriers. As the incubation periods of 1 to 5 days, so these carriers are potential patients. Then the convalescent carriers. Patients who have recovered from cholera may continue to excrete vibrios during his convalescence for 2 to 3 weeks. Then the contact or healthy carriers. Result of subclinical infection contracted through the source of infection or infected environment. And last of the chronic carriers occur infrequently. Longest was found to be over 10 years. Gallbladder is infected in chronic cases. Source. The major source of infection are the stools and vomit of cases and carriers. Large number of vibrios, like 0 to 10 is to par vibrios per ml of fluid are present in the stools of the cholera patient, and average patient exceeds 10 to 20 liters of fluid. So you can imagine the number of the vibrios. Carriers exceed few vibrios that cause 10 to 2 to 10, 5 vibrios per gram of stool. Mode of transmission. Transmission occurs from man to man by fecally contaminated water, contaminated food and drinks, then the direct contact through contaminated hands and excreta and vomit of the patient, and also contaminated linens and fomites. Incubation period from a few hours up to 5 days, but commonly 1 to 2 days. Period of communicability. Cases 7 to 10 days, convalescent carriers 2 to 3 weeks, and chronic carriers 10 years or more. If we see the pathogenesis in the large intestine, bacteria multiply rapidly, then bacteria release toxins which penetrate into the intestinal wall, then toxins prevent the absorption of water by the intestine, leading to hypovolemic shock and dehydration. Clinical features. Severity of cholera is dependent upon the rapidity and duration of fluid loss. By the vomiting and the loose motion, there is loss of skin elasticity and low blood pressure. However, a typical case of cholera shows 3 stages. Stage of evacuation. First one, onset is abrupt with profuse, painless, watery diarrhea followed by vomiting. Patient may pass 40 stools in a day and stools have rice water appearance. Then the stage of collapse. Patient soon passes to stage of collapse due to dehydration. Classical signs are sunken eyes, hollow cheeks, scaphoid abdomen, subnormal temperature, absent pulse, unrecordable blood pressure, loss of skin elasticity, shallow and quick respiration, decreased urine output. Death may occur due to dehydration and acidosis resulting from diarrhea. And third is the stage of recovery. If death doesn't occur, patient shows signs of clinical improvement. But if anuria persists, the patient may die of renal failure. Laboratory diagnosis. Diagnosis on clinical grounds can never be made. Laboratory methods are required to confirm. This includes a collection of stool, vomiters, water sample, food sample, transportation, direct examination, culture methods, characterization, and biochemical tests. Levels of prevention includes a primary prevention, which includes a health promotion and specific protection. Health protection, the most effective prophylactic measures, it should directly mainly to the effectiveness and simplicity of oral rehydration therapy, the benefits of early reporting for prompt treatment, food hygiene practices, hand washing after defecation and before eating, the benefits of cooked hot foods and safe water. Since cholera is mainly a disease of poor and ignorant, these groups should be tackled first. Specific protection. Cholera vaccine consists of two doses subcutaneous at the interval of 4 to 6 weeks. Boosters are recommended every 6 months. Not recommended for pregnant and person with previous history of sensitivity reactions. Oral cholera vaccines are often used as an emergency medication in the event of severe outbreaks. This is complemented with improved sanitation, increased in awareness about cholera prevention. Secondary prevention. Secondary prevention is supplied by the rapid investigation of close contacts to ensure their proper treatment. Control and treatment of cholera. Best way to control cholera is to develop and implement a national program for the control of all diarrheal diseases. Because of similarities in epidemiology, pathophysiology, treatment and control of cholera and other acute diarrheal diseases. The following account is based on the guidelines for cholera control recently proposed by WHO. So in this case, there should be the verification of the diagnosis, confirmation of the outbreak as quickly as possible. Investigation of all cases of diarrhea for the specific diagnosis of cholera, identify Vibrio cholera 01, the stools of the patient. Then the notification. Cholera is notifiable disease locally, nationally, and internationally. Health workers should be trained to identify notified cases immediately to the local health authorities. Then the early case finding, then the establishment of treatment center, necessity to establish easily accessible treatment facilities in the community. Then the mildly dehydrated patients, which are over 90% of the cases, should be treated at home with oral rehydration fluids. Severely dehydrated patients require IV fluids should be transferred to the nearest treatment centers or hospital. In areas where peripheral health services are poor, then mobile teams should be established at district level. Rehydration therapy. Cholera is now the most effectively treated disease. Mortality rates have been brought down to less than 1% by effective rehydration therapy. The rehydration therapy may be oral or IV. Oral rehydration. Packets of oral rehydration mixes are freely available at all primary health centers. The contents of packets are dissolved in 1 liter of drinking water and consumed within 24 hours. In this packet, WHO mixture of salts is not available at home. The table salt 5 grams and sugar 20 grams dissolved in 4 liters of drinking water can be easily used, which is called indigenous ORS or homemade ORS. It's simply 1 teaspoon is equal to 5 grams. It means in 4 glasses of water, you have to add 1 teaspoon of salt and 4 teaspoons of sugar to make homemade ORS. Older children and adults are given water in addition to ORS according to dehydration level. So it is the CDC picture how to make, or just you have to wash your hands, boil the water, then add salt and make it. And according to the situation, for the toddler, it is right. And for the condition of the patient, if it is not settled, then it should be taken to the hospital or health facility. Then the intravenous rehydration is usually required only for the initial rehydration of severely dehydrated patient who are shocked and unable to drink water. The solution recommended by WHO for IV use are the Linger Actates or Hartmann solution or diarrhea treatment solution DTS. Maintenance therapy after the initial fluid and electrolyte deficit has been corrected. Oral fluids should be used for maintenance therapy. The guidelines for maintenance therapy are given, and according to general principle is that the oral fluid intake should equal the rate of continuing stool loss, which should be measured. Diarrhea usually lasts for 1 to 2 days. Then there should be sanitation measures, then the chemoprophylaxis, and the tetracycline is a drug of choice, then the vaccination and the health education. Adjuncts to therapy. Antibiotics, tetracycline, most effective and superior to furazolidone, chloramphenicol, and sulfaguanides, should be given as soon as vomiting stop, which is usually after 3 to 4 hours of oral rehydration. No other medication should be given like antidiarrheal, antiemetic, antispasmodics, or corticosteroids. If diarrhea persists after 48 hours of treatment, resistance to antibiotics should be suspected. Recent advances. In one of the articles in the Science Direct, there was a chart. This was a number of cases, and this is year. It was from 1989 to 2017, and the color shows it was done in Africa, Oceania, America, and Asia. There are many similarities in the spread and dynamic and risk factors for cholera in areas around the world where the disease occurred, but there are also important differences. In Asia, many parts are endemic for cholera and have seasonal recurrence of the disease. The global cholera picture continues to evolve and will likely change in the coming years, but it appears certain that in times to come, cholera will continue to affect impoverished populations without proper access to adequate water and sanitation. According to European Center for Disease Prevention and Control, cholera cases have continued to be reported in Africa and some areas of Asia. According to WHO, vaccination should be considered for travelers at high risk, such as emergency and relief workers who are likely to be directly exposed. Major ongoing outbreaks are being reported from Afghanistan, Bangladesh, and Democratic Republic of Congo, Ethiopia, and Nigeria. Since the last update on 16 February 2022, approximately 30,629 suspected cholera cases, including 39 deaths, have been reported worldwide. In Pakistan, though no epidemic of cholera has been reported in Pakistan since 1967, present status of cholera infection is not exactly known in our country. It was one of the figures which are given in 2011, which was 527 cholera number of cases were present in Pakistan. After that, there is no data available about Pakistan. Cholera control. The objective of this guidance document is to support the public health professionals in implementing effective surveillance of cholera in at-risk, endemic, and epidemic areas. This document has been developed by the Surveillance Working Group of the Global Task Force of Cholera Control at the World Health Organization based on the exercise documents, guidelines, tools, and articles related to the surveillance of cholera disease, as well as technical decisions with experts held during CTG-FCC meetings. For cholera, key factors for effective surveillance includes existence of a standard case definition, simple data collection tools, clear reporting procedures, analysis plan, rapid diagnosis of suspected cases and laboratory confirmation, routine feedback of surveillance data, and appropriate coordination at all levels of the public health sectors, for example, community, health facility, district, national, and international levels. Cholera is preventable and manageable. There are few tools to prevent infections, such as the oral cholera vaccine, and it is inexpensive, efficient treatment that had been available for decades, in particular oral rehydration solution, but the health sector alone cannot prevent and control outbreaks. The best way to prevent cholera and other waterborne diseases is with the investment and maintenance of community-wide water, sanitation, and hygiene facilities. Peru, Vietnam, and Senegal are examples of the countries which have largely eliminated cholera outbreaks after investing in water and sanitation infrastructure and implementing targeted public health interventions. Ending cholera, a global roadmap to 2030. It is a new global strategy for cholera control at the country level, developed by the Health and Development Organization, including WHO, through the Global Task Force on Cholera Control. The goal is to reduce cholera death by 90% and to eliminate disease transmission in as many as 20 countries by 2030. The roadmap proposes that more effective control will be achieved through targeted and sustained preventive interventions in cholera hotspots, including the provision of clean water, adequate sanitation and hygiene facilities, and access to oral cholera vaccine. The roadmap was endorsed this year at the World Health Assembly as part of Global Solution to Address Cholera. About Cholera Kits 2020 by World Health Organization. The revised Cholera Kits 2020 are designed to help prepare for a potential cholera outbreaks and to support the first month of initial response for 100 cases. The overall package consists of 6 different kits, each divided into different modules. It is a diagram I show you in the next slide more clearly. So you can see it's the treatment kits. There are three kinds of treatment kits that each have supplies for 100 people: central, peripheral, and community. Okay. It is the oral rehydration salt, cups, IV fluids, giving said drugs, cholera beds, chlorine test kits, medical equipment, jerry cans, plastic baskets, sampling materials, soaps, examination gloves, and sanitary stationery documents. So for the 100 people, WHO cholera kits are tailor-made to prepare for outbreaks and to meet the needs for the initial response. Then there are investigation and lab kits. As you can see, rapid diagnostic tests, sampling material, examination gloves, filter paper, growth media, Vibrio cholerae, anti-sera, and antibody tests. And the hardware kits which to create pop-up clinics when none exists. Tents, water tasks, chlorine test kits, solar lamps, cholera bats, plastic sheeting, and squatting plates. So these are the WHO cholera kits. Cholera prevention and control in Asian countries. In this, they have shown that there should be strategic initiatives, social mobilization, and health promotion by empowering population, which includes enhanced community participation through community-led programs, run advocacy awareness campaigns in school and media, tailor campaign to local specificity, language and culture, and link cholera to other existing health programs. And there should be the collaborations between central provision and local authorities, local health units, collaboration with UNICEF, WHO, Save the Children, collaboration between government, professional bodies, civil society, medical associations, intersectoral collaboration, and cross-border collaborations. Then there should be initiative of WASH, which is water, sanitation, and hygiene. Get communities on board for them to cooperate in WASH implementation, raise awareness on hand washing, open defecation, hygiene, and food safety, ensure manageable, safe, and monitor water supply, develop WASH packages adapted to local population, focus effort on school, and implement food and water safety laws. So now moving towards the multiple choice questions. A watery stool sample was collected from a 5-year-old who is suffering from diarrhea for 2 days. After the incubation is high pH media containing NaCl, smooth and round colonies appeared. Gram-negative motile comma-shaped bacteria were observed after the microscopic examination. Name the possible bacteria: Aeromonas, Hydrophilia, E. coli, Helicobacter pylori, or Vibrio cholerae.
D.
Yes, the correct answer is D. Vibrio cholerae is a gram-negative comma-shaped. Cholera is predominantly mainly in developing countries where there's a lack of clean drinking water supply. Name the type of diarrheal infection associated with Vibrio cholerae: acute watery bloody diarrhea, acute ricey water diarrhea, mild water diarrhea, acute watery diarrhea with no blood.
D.
B is the correct answer, acute watery rice water diarrhea. It is the main feature of cholera. Which of the following biotype of the Vibrio cholerae is prevalent in developing countries? EL chalk, classic, biotype 0139, biotype 139.
A.
Yes, the correct answer is EL chalk. Cholera is an acute diarrheal disease caused by infection of the intestine. All of the following are the common cholera symptoms except diarrhea, dehydration, vomiting, and high-grade fever.
D.
Yes, D is the correct answer, as high-grade fever is absent in cholera. Which of the following is the most commonly used, easy, and effective method for the treatment of cholera symptoms in developing country? A. Continuous oral dehydration with electrolytes. B. Intake of omeprazole medication after onset of cholera infection. C. Vaccination method. D. Intravenous fluids.
A.
A.
Yes, A is the correct answer. People can get sick when they swallow food or water contaminated with cholera bacteria. Most powerful mode of transmission of cholera is flies, food, fingers, feces, fomites.
A.
C.
No, the correct answer is feces. Contamination with the feces. Cholera requires immediate treatment because disease can cause death within hours. WHO recommendation for use of antibiotic against cholera is ampicillin, chloramphenicol, tetracyclines, cephalosporins, and penicillin. Anyone? As I have mentioned, By WHO, tetracycline is a drug of choice in the treatment of cholera. So C is the correct answer. Cholera vaccines are effective in preventing cholera. Which of the following statements is true regarding cholera vaccine? It is highly effective, given in a dose of 0.05 cc. It contains 500 millions of Vibrio cholerae, given in 2 doses, 4 to 6 apart, contains Anaba strain only.
D.
Yes, D is the correct answer. It is given in 2 doses, 4 to 6 weeks apart. In case of cholera, healthy individuals are given antibiotic with the aim of protecting them against the diseases. Chemoprophylaxis with tetracyclines is indicated in cholera cases for pregnant females, children below 5 years of age, elderly above 65 years of age, household contacts, doctors, and paramedical staff.
D.
D is the
B.
D is the correct answer. In case of cholera, the household contacts are given chemoprophylaxis with tetracycline to prevent them from being sick. With effective antibiotic treatment, stool of an infective case becomes Vibrio cholerae free in 12 hours, 24 hours, 36 hours, 48 hours, or 72 hours.
D.
48 hours.
Yes, D is the correct answer, 48 hours, because the patient should be free of cholera. If symptoms suggest that there should be assumption of drugs resistance. This is my key, and thank you so much.
Thank you very much, Dr. Sadia. Very nice presentation. And one of the very important fact is that when Pakistan came into being after independence, we don't have any vaccination center where the vaccines are being developed in Pakistan. So it was the time when the cholera epidemic struck the poor nation, and especially the immigrants that have been migrated recently from those areas that were now in India. And in most of the camps where these immigrants, they were residing, there were lots of deaths and miseries due to cholera. At that time, the pathology department of King Edward Medical University came forward, and they started producing vaccine, that is the cholera vaccine, for the first time in Pakistan. And that has helped many precious lives to be saved from the cholera epidemic. Another important point that have been further asked many times by the students, that if we have chemoprophylaxis that is available and that is very efficient, then should that disease, we should label them as epidemic? The answer is yes. Still, when we have a very good chemoprophylaxis, still we have many types of the diseases like meningococcal meningitis and cholera that still have the potential to become epidemic. The reason is the chemoprophylaxis that is available, but still people are not using it, the context, they are not aware of it, and mostly the patients were prescribed treatment without giving the chemoprophylaxis to the context. And that is the reason that still the number starts increasing. And once there is a rise in number, the outbreak occurs, and the outbreaks usually turn into epidemics in those areas that are highly vulnerable to it. These are my few points in this discussion. If anybody has any question or suggestion, please do let us know. Okay, thank you very much. Dr. Sadi, very nice presentation, and you have a very beautiful style of presentation. Please keep it up.
Thank
Allah
you.
Hafiz. See you
Allah
all
Hafiz.
next time.